Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended. So, this is a 43-year-old young male with a mature intumescent cataract, and the plan was to do a mini Rhexis first, then decompress the bag, and then enlarge the Rhexis. So I was able to manage this mini Rhexis, decompress the bag as well, but then the Rhexis still went out. So let's see how things went about and how I managed this case. So by now the capsule has been nicely stained with trypan blue dye, and this is a triplanar incision made with the help of this 2.8mm steel keratome. So now a nick is made in the anterior capsule, a flap is raised, and then with the help of this Utrata, I'm aiming to create a small Rhexis. And we get a good Rhexis. Now I'm trying to decompress the bag with the help of this Simcoe cannula. So one thing I found peculiar was that this cortex was very sticky, and after several attempts some of it came out, but still I feel I should have given more time to clean this sticky cortex. Now I'm trying to rotate the nucleus, and then again going in with my Simcoe cannula to clean up more of it. So this rotational movement as well loosens the cortex from the posterior aspect, and it just flips over and comes out of this small opening. So you can see I'm trying to loosen up and remove this cortex, but it's refusing to come out. Trying to milk the bag, still no success. So now I decide to leave it as it is and enlarge the Rhexis. So with the vanas I make a small nick. Now I have done this quite a lot of times, but this was surprising. So now I am holding it with my Utrata, and you'll see the moment I start the Rhexis, it just runs out, and there's no way I'm going to get it back. It has definitely gone to the zonules. So now several things are going in my mind. He's a young male, so I need to be very careful. So now I have planned to increase the Rhexis, making a nick with this micro scissors, and then again holding it with Utrata. Still the capsule opening is small, so I make another nick, and then finally I got a good sized Rhexis. So now the option was to continue with phaco or go with SICS, but as it is a soft nuclei, so I plan to do a supracapsular phaco. So I gently dial this nucleus out of the bag in the anterior chamber, and this is Oatley's Catrax 3 phaco machine. The parameters are power is 30, flow rate 38, and vacuum 400. So now I am able to crack this nucleus into two and then further sub chop, and I've got two quadrants which are emulsified easily, and then this second heminuclei is dealt with and it easily emulsifies. I'm trying to be at the iris plane. That's it. In no time, I'm able to manage this soft nuclei. And now the time to clean up the cortex. There's not much of cortex left. Most of it is the fibers which are stuck to the posterior capsule. So I have dropped the plan to polish them, as I can do Ya caps lot me later if need be. So a wound assisted implantation of this hydrophobic IOL is being done carefully. The leading haptic goes in the bag, gently nudged in, and then the trailing haptic is dialed in. So the centration of this IOL is good. And now I'm gently removing the OVD from the bag. I'm not planning to go behind the IOL as I don't want to risk it. So I gently tap the IOL and remove as much of OVD as possible, and that's it. So the take home message is, if things don't go as you plan, you should always have a plan B. So in this case, I had two options. One was to continue with phaco and the second was to convert it into an SICS. So as the nucleus was soft, so I decided to go with phacoemulsification in this case. But if it had been a hard nuclei, I would have definitely gone with the SICS. So that's it. Some loose fibers are there, but they'll resolve. So I plan not to touch them. And that's it. The case is done. Let me know how you found this video, and thanks for watching.